think crazy what I'm about to say.
Welcome, welcome everyone.
Hot air balloon that could go to space.
Hello. Can you all hear me? Can you all see me? Hi, and can you hear the music from Hiranti's side? I can't hear anything. So welcome everyone. Hi Sabrina. Hi me. Hi Silma. Hi Amra. Hello Shani. Welcome. Okay, Hiranti, you can go ahead with the music because I can't hear it. Can you reshare, please? Hello. That's okay. So if you don't have the music, not a problem. So what we're going to do, everybody, if you can hear me, give me a thumbs up, a reactions button. Okay, great. Okay, so what are we going to do? So it's the end of the day and we're getting ready for a talk that I've been waiting for since last year. Okay, so we're just going to shake our hands, shake, shake, shake. You've had a long day, so you're going to shake them all the way top, down, down, down. Roll your shoulders back. Breath in through your nose and out through your mouth. And then roll your shoulders forward, breath in through your nose and out through your mouth. Then you're just going to drop your head if you have been at the computer, if you've had a stressful day. Just drop your head to the left and allow a natural stretch. You don't need to press your head down. Just let the weight of your head do what it needs to do. And all these small movements will just stimulate in our vagus nerve. Very tiny things, amazingly. Then flip to the right. Great. Okay, with your next breath in, what you're going to do is you're going to take your fingers, you're going to start combing your neck like that. Breathe in and out through the mouth. In again, out through the mouth. Just comb your neck from side to side. I wonder if you can hear me. So continue.
Your voice sometimes is low.
Great, everyone. And the next thing, you're just going to make a V with your fingers and breathe in. Push out behind your ears. Go like that. So push from your jaw back behind your ears. And do that. Okay, how is everybody doing? You can let us know in the chat how you're doing. You can unmute and share as well. And now, what are we going to do? We're going to sit and listen. Take a moment to create our intention that we bring our best hearing and listening today. Okay. And welcome Professor Samir Al-Adawi, who was my mentor, who I learned from. It was my first experience of having a mentor after graduating my degree, my first degree, my bachelor's. And I was nervous going in to meet Sir. Like I was referred in, I had to go for an interview. That was one of the fastest and most empowering interviews I had. He asked me like, hey, what do you want to do? I said, well, sir, I'm here for this. I want to get the experience. I just want to learn. I want to know. Okay, I've got the attitude. That's fine. Come on in. And I was like, wow, amazing. Like, what an opportunity. I made a student who just graduated, maybe just a few months ago, to feel like, wow, this person who was, with the medical faculty at the Sultan Qaboos University, just said, okay. And I was like, wow, okay, that's a great opportunity. Thank you. And I learned so much from Professor Samir. One of the things that I am so grateful for that experience, thank you very much, Professor Samir, is the fact that it is from him that I learned to be reliant on the fundamentals of what you learn from your training. Like if neuropsychology, now sir's work is in neuropsych as well. So how you do certain testing, when you get reliant on the test material, you feel like, I don't know how to assist this person who's coming in. What can I do? It was from him that I learned to be resourceful, to say like, okay, I have the knowledge. We're looking at attention. We're looking at, long-term memory. We're looking at short-term memory. We're looking at spatial recognition. So don't be so reliant. See what you have in your clinic. What do you have that can be similar, just to get an understanding? You're not diagnosing anything, but you even have an impression to move forward. So with that, moving forward, I want to move forward to welcome Professor Samir to share ethical considerations in a psychotherapeutic practice. Thank you very, very much for taking the time out to do this for us, sir. Thank you.
Thank you for your kind introduction, and I'm honored to be around your colleagues. I assume everyone is from at home, isn't it? Or they are from other places? Just Sri Lanka? Okay, so nice to meet everyone. So is my voice clear to your side?
Absolutely.
Okay. So yeah, so most of the discussion lately tends to hinges on psychotherapy. So I decided to highlight on ethical consideration, which is more important, just like technical skills in psychotherapy. Okay. So as always, those of us who works in academia, I don't have any conflicts of interest, and I'm editor of SQU Medical Journal. So some of you may want to consider this international journal that we run here. Okay, let me get so because we are so much into psychotherapy all the time, I use this haiku poem. It's a clouds come from time to time to give a man a rest from looking at the moon. So the moon here is psychotherapy. So today you can take time away from, specific therapeutic technique, and we will focus into 4 things, what they call therapist-patient relationship, or in the literature, this one is called doctor-patient relationship. And then we look up on the model of therapist-patient relationship, and then I will emphasize in therapeutic relationship, there is a very strong emotions between therapy and the client. And later we'll go for special ethical issue to be considered. So this is some form of doctor-patient relationship. And it's a central to psychotherapy medical practice, particular now, even physicians who are using medications they say nowadays most of the disease are sort of lifestyle disease, so they will require education. So this relationship communication is very important. So it's not only a practice, but is also linked what they call it bioethics or professionalism. Okay, so other term that came like a therapist-client relationship, doctor-patient relationship. If you Google it, you look for doctor-patient relationship, but sometimes the other terms come, including therapeutic relationship or therapeutic alliances. So in psychotherapy, they say therapy, a patient, is like a mirror where the patient wants to see themselves. So I just want you to think about this term. We could discuss it later. So what does the term means in healthcare setting? I want you to read this and see whether you understood this definition. First is either A is a legal agreement between a healthcare provider and a patient. B, a collaborative and trusting relationship between a healthcare provider and a patient. C, a financial arrangement for medical treatment, or here we can say for psychotherapy. Regulatory guideline for healthcare profession. And if we move to the next slide, you'll find that the answer is collaborating and trusting relationship between a healthcare provider and a client or a patient. So why is this relationship, which we'll tackle throughout our discussion here today, why is it important? Studies after studies have found it increased both the healthcare giver or counselor, psychotherapist, psychologist, and their client satisfaction. It also, when you want to intervene, the patients are likely to follow your instructions, to do their homework if it's psychotherapy. Also, as the result, more appropriate decisions are made, and obviously the net outcome is that you can see the better person will improve or they will get better. Okay, so that's about the doctor-patient or counselor relationship. What are the model of this relationship? And from your own experience, you'll find there are different type of patients: dependent patients, controlling, those who cause drama. Some of them are suspicious, or some of them looks superior. I wonder, some of those you must have encountered in your practice, I'm sure. There are people have defined in terms of relationship. One is called paternalistic model. When you think of it, it's like you are acting as a leader, mostly like a father or guardian, and then you inform the client what the best to what is best for them. So maybe you will interview them, follow up, and then you can say, well, you are depressed, or you have this, that sort of things, and this is what you need to do, and let me help you to do this. This is called a paternalistic model. The other one, the second one, is counselor inform the patient, you are having this and this. So they don't really, take command of the patients. Now, the third one is called interpretive model. And this, let's say you do, as we discussed earlier about your psychology test, and then you may tell the patients you have this and this, or you do, psychological examination. So you just interpret. Most of the discussion is, which one do you actually use? I think young populations are rather be informed or they like to be interpreted. My generations, when we see a counselor, doctor, we want him or her to take charge of us. So we don't want to advise us. They just want to tell me, I want the doctor to tell me, this is what you need to do. So that is the paternalistic, but it could be different between places to place, generations to generation. Then there is another type is directive, non-directive therapy, and the relationship can actually change. So directive, as the word suggests, is like those psychotherapy where there's a dialogue between the patients. You can think of non-directive therapy like Freudian one, or some of those humanistic psychotherapy where the therapist act as a facilitator. So what we know also, people respond to therapy according if they are educated, they are psychological minded. When I was young, there was a word called yappy, and yappy means young, urban, and professional. So these are the type of patients that often come to the therapies. They are very open, they are very conducive. We don't get all these patients all the time. They are, they don't want to open up, and young generations are different, but some of older generation, they tend not to really open up. So that's the third part about the model of, this therapy-client relationship. But we know the relationships are more complicated. We talked about therapeutic alliance, means you have to side with your patient. The patient has to trust you. Then because of this bonding, sometimes they may develop transference. If the patients have some emotional issue towards you, or something called countertransference, where you will have some emotions towards your patient. You become irritable, you may fall in love, you may hate them, you may be scared of them. And this is Freudian concepts, but is often highlighted in all entrance to even modern psychotherapy, because we see these sort of things. And most psychotherapists are required to handle this transference and to make sure that they don't go through themselves going through what we call here countertransference. So the therapeutic alliance is a cornerstone of psychotherapy. Okay, so there are many benefits that one, when there's agreement or contract. So if you're seeing a patient, some of you who are very young, better sort of having rapport, establish what you're going to do, what you're going to follow, that sort of thing. So that's a definition of a therapeutic relationship. So let me bring this as something we can think of. Which of the following statement best describe the differences between directive and non-directive approach? So please spend few minutes and try to figure out the answer. Take your time. Okay, so I'll go to the answer place, which is, the best discriminations, the distinction between directive and non-directive therapy is that therapy, it's more guided, where non-declarative is not, it's more, patients, the therapists don't really interfere. Just like some of you may have got exposure to psychoanalysis, where there's a free association, as they call it. So let me repeat this important issue of countertransference and transference. So if the patient has some emotional issue towards you, that's transference. Countertransference is the, you are having some projection or emotions to your client. So transference definition now is characterized by unconscious redirections of feeling from one person to another. Okay. So I used to depend on my mom, like all of us, our parents take care of us. So someone take care of me in the therapies. I developed that childhood role in, some people call it regress to your childhood. And it may not be the same, but that's how things work sometimes. So the idea here is that your patients regress and you become a mother figure or father figure. They depend on you. Another important issue that often impede, psychotherapy is that some patient comes in with malingering, or they may be having what they call it illness behavior or sick role. These are the terms they often use to imply that, the illnesses has some function, some secondary gain to the patients. And sometimes it may not be very easy to pick it up. So you may be dealing with someone, only the illnesses have some role to escape some situations, but they may not be presenting as they have, what they are presenting to you. This is a huge dilemma in psychotherapy or healthcare services, because a lot of patients, they become sick, they get attention, and they get reinforced for that attention, and they become more sick, and so on. There are also other disorder they call somatoform disorder, like malingering, somatoform disorder, fractious disorder. They are related to this. I will encourage you to read, because they are quite often particular in a developing country. Okay, so this is the issue that often comes with any discussions about, these ethical principle and, practice psychotherapy, all this. So what is required is that you have to become competent. You have to give informed consent. There should be boundary, and this is very important because we only talk about earlier, just few seconds ago, about transference and countertransference. But also you should establish that therapeutic boundary. That means, you have to put your feet in their side, sympathize, but still be away from there. And also another issue is also cultural sensitivity and diversity. Nowadays, there's a lot of conflicts of interest, particular, those people who prescribe medication. And there's also important to safeguard client welfare and how much can we actually do. And I will highlight some of this. There's also issue with psychotherapy or any medical practitioner, legal and regulatory compliance. And if you are doing psychotherapy, better attach to your colleague sometime for consultation. If you are junior, then you can also seek some supervision. And finally, it's about confidentiality, which sometimes is kind of difficult because medical reports or patient's information are stored in a computer, or you communicate via online, there's telemedicine or online sessions, and this can actually compromise. So these are some of the issues that comes in psychotherapy, and I will choose some of them and discuss them here. So we are on the last issue here, is called ethics, special consideration. And some issue I thought we should go through include relationship, intimacy or sexual relationship, issue about privacy, informed consent, and also gift from the patients, And also interesting issue for both Sri Lanka and Oman is this cultural diversity. Remember, most of the psychotherapeutic technique were developed mostly in North America and Western Europe, and how much of it actually work in our society. So I will be like a devil advocate a bit here, just to, to highlight this diversity and some of the challenges. So sexual relationship between therapists and clients, we are all trying to be ethical, but this is a huge, slippery slope many people can follow through. And proper training, that's why always collaborate with your colleagues, have supervision if you're junior, and if you're senior also, you can vent to your junior members, because sometimes by discussing what going through the therapies, the other people, they say, maybe you are experienced this and this. So sexual relationship between patients is not something rare. This particular study that is in front of you, they found that most of the therapies, 29% of them, they say they had this encounter with the patient. So it's not, something that is just outlier or very rare. Now, this is another study. They show here, this is a big study, it was done in Belgium, and the numbers of participants of therapies were 558, were all therapies, including medical one and psychological one. So 3% started having relationship with clients, 3.7 during therapy, or 13.4 started a relationship after therapy. 70, this is not a relationship, but they get, attracted, with their client. 25%, they fantasize that romantic relationship. And then 22%, they say they hug their patient after the session. It's also cultural issue. In some of our Eastern culture like us, maybe hug is not very often, but in the other country, it's a normal practice. But then, is it allowed in therapy? And in terms of gender, more males reported this sort of, feelings. And interesting, psychiatrists report less sexual feeling than the other psychotherapists. And then behavior therapists report less than other psychotherapy, like, psychoanalysis or things like a client center. Okay, so what are the literature say? What our regulatory body says? There's a body for those who do medical training. They took an oath. It's called Hippocratic Oath, and they forbid that relationship. In fact, these rules came from ancient Greek, and they are still with us until today. Some people are saying no, with not, people are independent, morality have changed. If the two adults agree with each other, what can we do? Why should we be inhibited? So that is the counter argument, but the rules are still say no, it's not allowed. And those who say it's not an issue, people, you as a psychotherapist, you have your own privacy. You can decide who you want to love or be loved from. And then they argue, which is probably wrong. They say lack of harm to the client. There is a huge literature. They say it's the other way around. It harm the patients because the role that they have, the projection they see, towards you may not be actually beneficial to the patients or you. And then some people use this metaphor like you're working in a small village or small town, and where would you meet anyone? You maybe this is the only people you will see in your life and socialize and become friends. So this is people who say this is needed. But as I said, none of the regulatory bodies are actually, not adhering to the ancient Greek rule. And the rule is that it's unethical, including American Medical Association, British Psychological Association. In other words, all the lists in the world, if you can think of. So the objections are the following. First of all, you know, this is taking advantage because you have a lot of power, which you will not get that in other contexts. And then if you do relationship develop, I may not bring, for example, my wife to your clinic or my daughter or my son or something like that, so that profession will be undermined. And mind you, there are some clients, some patients who are very vulnerable, who, the nature of their personality or mental state, they can easily fall prey into this. It could be also, some of those missing gaps in their life. They miss their trusting person, and the therapist tends to be very trusting. They're listening and could be make them more vulnerable. And again, if it leads to the court, if anyone take an action, and this is a considered to be criminal charge. So there is no counter argument according to the existing regulation. So what happened? What shall you do? Recognize early sign. Better, as I mentioned earlier, is always have some people that you can vent about your therapy. It's not a gossip. Actually, it helps, provided your colleagues will not take your information and inform someone else. So always seek advice. And the best bet is that you should not antagonize them. And then if you feel very vulnerable, talk to your colleague, maybe transfer the patients to another colleague. And always don't show those weaknesses where you become very defensive and that sort of thing. Some of them are very manipulative by becoming defensive. They may pick up your weak and they can actually exploit that way. So another things to remember is that a question will arise. Let's say you meet someone 5 years ago in the therapy, in hospital setting, in your private clinic, then you encounter them somewhere else, non-hospital places. Can you start liking each other, exchanging telephone or email or joining Facebook, one of those. The idea is that once a client, or once a patient is always a patient. So since this is the first encounter with him or her was in the therapeutic setting, then it will always be a patient to you. So this is an important point to keep in mind. So what does that word actually means? So see if you can figure out here. A patient are expected to maintain therapeutic relationship with their therapist indefinitely. That's A. B, the therapist maintain a duty of care and confidentiality toward former patient even after the therapy ends. C, patient must seek ongoing therapy regardless of their current mental status. Final one, therapists have a right to continue providing unsolicited advice to former patients. So keep in your mind the right answer and test yourself. So the answer is that once a patient is always a patient, imply that therapists maintain a duty of care, confidentiality toward former patient, even if the therapy ends. So even after, we are referring to about relationship, but even revealing their private information will always should be not be revealed in public. So I'm coming back to keep you awake. The word again about transference, because transference is, if you think of it, is the emotions from the therapist to the patients or patients to the doctor. So transference in psychotherapy, what does it mean? So please read and test yourself. Okay. So they use, psychoanalytic terms, clients' projection of feeling into the therapist based on their past experiences. So it could be their remind them of your mother because of your care or your father, one of those. As I mentioned earlier, transference and countertransference is highly introduced in graduate school psychotherapy. Okay, so now move away from the first ethical issue. The second is confidentiality and privacy. This is not very difficult, but it became very hard to maintain sometime because of issue of privacy and security. So you will not, you will keep the information safe, whether in your mind or in writing, but sometimes there may be privacy issue, security issue. And as you know now, a lot of things may be done via internet, telephone, phones, online, that sort of thing. So privacy is something is unknown, and the security for it is also unknown. But we know very well there's an issue about confidentiality. It should be part of your professional health. So it's considered one of the duties in psychotherapy, means you keep all the information private unless patient consent to release it. For example, in our society, we see a doctor who is 23 years old. The mother would come and say, I need a letter. We say, no problem, tell her, both of you come to get the letter. Later simply that she's attending the clinic. So it could be some of those sort of things on confidentiality. And there are many cases where we have some problem where there is a strained marriage, and then one of the couple will take the wife to the hospital for marriage counseling, something like that. And they will open a visit, say, for the woman or lady or wife. And later they will come back and say, can I have a report that she's attending the clinic? And they use this later to accuse the wife that she's not capable for custody of the children. So all of those you have to be aware, and only the patient has to consent to what you needed. So, a lot of things that can come out in the therapy, and then you are expected to keep them, private, confidential, that sort of things. There are cases where these things can be broken. And try to remember, for those of you who may all go to graduate school, on psychotherapy or clinical psychology, this is something that you will be told there. So there are exceptions. You can break confidentiality if there is injury caused by weapon or crime. So if I come to you with PTSD or just acute stress reaction, and I've been injured by guns and all that, you are authorized to break the confidentiality, inform the authority. If the second is that there is a potential violence of the client to others, let's say I come to you and I say, when I go home, I'm going to kill my so and so. I'll go to work, to work, do some that sort of things. So this is also can be broken. Third is the someone may have infection. Let's say you meet a patient who's very promiscuous. He has HIV or related conditions, sexual transmitted disease, and then he appear, he do these things, and he admitted to you he has multiple relationship, and you ask the person whether they are safe. They are not using safe routes, so you are supposed to break, confidentiality there. In Oman, we have infectious disease surveillance system, so upon informing them, they can follow it up for obvious reason. Infection can spread very deeply into the community. This is one of the mechanisms that can be stopped. Now, the other side is to protect the patients. There's something called child abuse. So if I was a child coming to you and you suspect or I admit that there's a child abuse, let's say here in Oman and the places I was training in the West, there is a child protection team, and most countries have signed this. And I view this morning that Sri Lanka is also part of the child protection treaty. So they have this a system where you can inform the authority, or within the hospital, social service is one of them. We know because of improved healthcare system, elderly people, many of us live longer than before. And unfortunately, human nature is not that good. There's a lot of elderly abuse. And if you suspect that one, also you can break the confidentiality. Another one that is also common is domestic violence. Let's say a lady come, nowadays even men, sustain domestic violence. So you can inquire, you can advise them, and if you feel there is a danger and more, vicious cycle in this relationship, you could inform social services to, to help that person to maybe to escape, or at least to, you know, to show the abuser that this person has a choice and the person can be prosecuted. Related to confidentiality and privacy, but more specific for you practitioner, is something called informed consent. Informed consent is called share responsibility. And then this is obviously is done in psychotherapeutic, medical practice, or even research. So what do we mean by that? Let's say you are going to apply behavior analysis to child with autism or hypnosis or something that could lead to some setback. Maybe you don't even conceive it. So you better seek informed consent. And what do we mean by that? You inform the patient of the risk and the nature of the treatment, risk, benefit, and the nature of the treatment. And to go along, you are also, before I go, the exception where you are entitled to, it's better to have this habit, having a paper in your office, where the patients, sign. And if you are that type of therapist, you give, say, 10 session of CBT, you may give the reason, that sort of things. There are some psychotherapy that can also, like some of you may have heard of it, is my generation, we used to learn about it, like Gestalt therapy, where the therapy is very provocative and, confrontation. So people with a lot of ego can get very offended or become angry. But so better to tell them that I'm going to do this psychotherapy and this is what I'm going to do. Please sign here the consent that you agree to undertake in case something backfire. So how do you jump this one where you don't need, that is to say consent is not needed, when there's someone is cognitive impaired, so somebody mental retarded, dementia, something like that. If you have to make decisions with life threatening, You may feel these issues are often to do with emergency doctors, but there are cases where you will be involved. For example, someone is going through organ transplant or something like a cosmetic surgery, bariatric surgery, and you are supposed to, make decision for them. So you can actually deny them that consent because they cannot make decision, they are cognitive impaired. But if they are going to go through good causes, something you think they will, is good for patient to undertake, then you can override the consent. Obviously, if there is an issue about suicide, depressive mood, person will become in danger. So you feel the patient has to remain safe. Then you can inform the family, for example, that this person. So you don't have to seek allowance agreement with the patient. You can cut the corner and tell the family. There are cases where the patients, they say, I don't want to sign any consent. And this is with your right. You may note in your paper that they don't want to sign consent. They leave to you. If you remember, I talked about this relationship between doctor and patients. And this is a type of relationship where the patient wants you to become a father. They say, no, I trust you. I don't want to make any consent. Why consent is important? There were a lot of things were done to people. People did not agree. If you follow things like some of the behavior therapies that were used to treat, people with sexual minority, nowadays, when we reflect, we thought that was actually wrong. They should have consented, or simply we should not have done those sort of intervention. But if you are interested, there's a lot of discussion how history was wrong. And these laws and regulations are always refined as we go on. So what happened when consent was not sought? It could lead to malpractice or legal action. If a patient doesn't like you, can go to the police and say, this person did hypnosis to me, and I was paying these exorbitant fees to the therapist, or I was giving him or her money. This is not true, but once they say, you can deny that I didn't take money, but you can say, yes, I did give you hypnosis, but this is what I told the patient. So you can overcome this legal issue by, having this paper ready for them. So now gift in our Eastern culture is very important when we visit each other. I remember Rushma used to come with gift at the office. He was not a patient, but people share these sort of things. So what ethical committees will tell you. So take a hypothetical situation here. A patient comes with something here will be on the gift, like a chocolate, or he will have a key for expensive villa for you, or he will give you simple traditional dates we have there in Oman, or those expensive car that some of us can never imagine that will be able to sit there. So what is the rules here? The idea now, it depends on the context. If someone comes with a little box of Kit Kat chocolate or something like that to thank you, they are happy, that's okay. But if something looks too much, better declare. You don't have to reject it, better declare it. But before you accept any gift, please keep the context right. If you see this person is, fishing for something and this gift are just bribery, let's say, he wants some reports or he wants some, something for insurance or whatever, then you have to be careful. But the gift itself, it depends on the amount. If, for example, somebody is very wealthy, they give you 1 million and they are billionaire or trillionaire, then that's not the issue. Just declare it in the right office. So if it's small thing, share with your colleagues in the office. There's a chocolate, share it. If it's big thing and you feel you cannot resist because that person has respectability in society, rejection, after all they're giving you, they are saying thank you to you, what you have helped them. So if you feel this is a little bit too far, take it to the admin and inform them, and they will tell you, fine, you can keep it. We had some young ladies who worked with me, like Rushma. We contacted by private sector, and they say they need a therapist to visit because the young girl in the house doesn't want to leave the house. One of the girl agreed to go, and they went. They had a rapport. The girls improved, and then the girls, she went to say, I will stop the therapist because I'm going home and I'm going to get married. The father, who are very wealthy, they gave her enormous amount of money. If I tell you, you will be surprised. And the girl, she saw that bundle. It was not even bank transfer. It was a bundle of money. She called me and they say, the family gave me this money. What do I do? Can I come and drop it in your house? And I said, don't worry. Keep it until I see you tomorrow. Okay, okay, okay. She went and then she came in the morning. She showed the bundles. And I told her, this is yours. You deserve it, and you serve them. And they used to give her transport to move from her house to the residence of this girl. She didn't spend money herself or any of it, but I told her keep it, and she went back to her country. Hopefully, she put it into good use. So, gifts like this are acceptable. Share with your colleagues. It should not be secretive relationship. Money like that are not allowed unless this is a fees that you are charging. There may be some subtle things you have to be careful. The charge is this much, say 50 something dollars for convenient here, and the patients pay triple of that one. You may have to be careful that way. Or the patients, you book her or him for 1 hour, he go and told the administrator of the clinic or hospital that I want to take 4 sessions in a row. So he cannot, in other words, you cannot see her or him for duration of normal therapy. He want to buy the whole day. So here something is actually wrong in this sort of manipulation. So there's no really rules. It depends on the context. This is William Shakespeare says, if you are true to yourself, I'm paraphrasing here, practice day and night, no one will find a safe false on you. So intention is good, adhere to the rule, then you will not have any problem. The last is cultural diversity. And this is a topic that relevance to all of us. As I mentioned, that majority of psychotherapeutic approach were developed in another part of the world, and we are transplanting into a different culture. So what are the issue here? I will start with the parable of monkey and the fish. I'm sure some of you have heard. To paraphrase this, there was a flood, and monkey, so its friend the fish was struggling in the currency. So the monkey was very kind, and he was thinking he was doing a good thing. He went to take the fish out of the water, kept it out, and as you know from the story, the fish actually dies. So sometimes we have a good intention, but are we actually saving that fish? And I want to take this metaphor to our discussion on, psychotherapy in our region. I went to a center called Mosley Hospital. So the person who was named after the hospital I work, this is London. He say morbid mental phenomena of insane, Australia savage. Savage, by the way, used to be non-Western people. So I think Sri Lanka, Omani, or other were used to be called savages. But the word has changed, like the way, imbecile or morons, retarded have used to be associated with mental retarded. It was just a label, didn't mean something bad. It's just classification. So he said here, to paraphrase, he said they have different psychological states, so you cannot compare between, one place to the other. This is another quote from another famous, in those days they used to call them alienists, but today we call them psychiatrists. So, he's thought that, say, a country like Oman, Sri Lanka, the pace of life is very slow. So the mental illness, or they don't have that stress of civilization, of modernity, then you will not find this psychiatric or psychological problem. This is also a fellow who was in my university. He suggested that the language, other than Indo-European, they may not have these subtle words that to explain emotions. He argued that, for example, Yoruba in language in Nigeria or Kiswahili spoken in East Africa, they may not have word for depression. I don't know Sinhalese language or other ones in Sri Lanka. Do they have word for depression? But he was arguing they don't have. Then the question, if they don't have the words, maybe they don't have it. So these are sort of issues I think it's important to keep in mind, those of you who are practicing psychotherapy. So one of the issue in bioethics, they view the one particular from Western society is that you are independent, there is an individual anatomy. This is clearly a philosophy that was expounded by someone you may have heard, Immanuel Kant. So these issues that we just discussed, like consent, confidentiality, is based that you are a separate entity and we have to respect that. And we know this is in fact is not true in some society where the society, they have less independent, but they are more interdependent. So Laomani is such society. I will maybe predict Sri Lanka is also so. We are communal, we live with our grandparents and, that sort of things. So the problem is that independence, these ethical principles clearly are relevant. But interdependent society where you don't become individual, then there's a question mark. For example, here in Oman, sometimes a doctor will go and get consent, and the patient say, I don't need, you are the doctor. Or he say, ask my father or my mother to sign it. So this is what they do is part of interdependent, because that person is sick now. He wants the family to take over, as we often do in our culture. When someone is sick, family member take over. So what is the issue here? In dependent society, the goal of life, you're separated from your mother womb, then you separate from your family, and you become a separate individual, independent individual. In some society in Asia, you are part of the family, you are communal, literally relate. These are called communal society. So I have highlighted the background because you are psychologists, psychotherapists, and so on. So we deal a lot with the self. The self, if the society doesn't encourage the development of self, then the questions to you is that, you know, we because psychotherapy deal with intrapsychic conflicts, so you have to have that self developed to introvert, to look inside and try to answer that one. And if the cultural patterning does not give you that chance, then you may think, are we actually doing, do we need to do psychotherapy? The reason is that, for example, trying to bring this bioethics I just mentioned to you, like there's this interesting paper. He's suggesting that in the Arab family, if there was a child abuse of incest, sending them to the police will actually be detrimental because the girl was abused, will be ostracized in the community, and then social services are not there to support. So this is clearly, he was suggesting that let's look at the local context when we are actually doing psychotherapy. Another way of looking of dependent and interdependent and relevant for psychotherapy, if something goes wrong in interdependent society, they feel ashamed because these, socializing factors in the societies often tell you have to be shamed, otherwise people will condemn you. Whereas in individual society, where psychotherapy should work, usually is guilty based. So when someone is guilt, has intrapsychic conflicts, it's easy to do psychotherapy. So here I'm posing your questions. I don't have an answer for you about the complexity of these issues. What you want to take in mind is that you are trained in a psychological way. So society have their all different view. For example, here in Oman, when anything goes wrong, they attribute it to traditionally to spirit possession or supernatural forces. So when you started looking into their psyche as a therapist, the patients may not be finding that very interesting. And for some reason, we find more people because of this lack of communications between modern therapists and the society. Most of them go to this traditional healer that most of you may condemn them, that they like scientific merit and so on. And another thing that comes, what you need to be aware is that in therapy, you need emotions. So when patients who are grow up in as an individual, they may develop this psychological minded, so they can see this is an emotion. They are depressed, they are fearful, and so on. When there isn't that expression, or society does not, encourage or foster expressions of emotions, people tends to somatize. And I think I would encourage you to read about these distinctions because it may bring a lot of interesting issue for you. So then we are caught here. The patient, we are equipped to help with their emotions, but they come with the physical illnesses. And therefore, many of them would rather go to physician and they want medications rather than lifestyle changings or counseling. So in summary, those of you who are with me so far, we have looked at the importance of counselor-patient relationship, model of this relationship. There's also humans are very emotional. They come for therapy because of emotional issue. Then the relationship between patient of this therapeutic alliance can also take unusual turn. And then I discuss it for you some of those slippery ropes like sexual relationship, issue about professionalism like confidentiality and privacy, informed consent, gift from parents, and I hope I act as a devil advocate about cultural diversity and psychotherapy. So I want to thank you for your attention, and maybe we can hear each other now. Thank you.
Thank you very
Hello.
much, Professor Samir. That was hello. Can you hear me? Am I audible?
I can hear you very
Hello.
well. Thank you. Yes.
Okay. Thank you very much,
I
Professor.
think
That
some
was a very, very insightful session. Before I say any further, everybody on this call, some of them had messaged me saying a sudden emergency came up, so they had to drop off. Do you all have any questions that you would like to ask Professor Samir? Please unmute and share. Do not shy away from it. If you feel a little anxious, that's okay. You can always message us
Most of you
privately.
are
We can
muted, so if you speak,
yeah. So please unmute and share. Even if you want to share a statement or observation, go for it.
I'm here to learn from you. So anything is a dialogue, didactic sort of things. We can learn from each other.
Yes, absolutely.
All of you
So,
are what profession?
so there are a number of them that are in the field of mental health, with a master's in clinical and health. Some are just graduated from their first psychology degree, and there are others that I do not know about, which have joined this call. So, who would like to, unmute and speak?
Hi, Professor Samir and Dr. Rishma. The session was quite interesting and very quite engaging, I'd say. Right now, I just completed my bachelor's in psychology, so I found like I always had doubts regarding the gifts and like certain regarding how to maintain confidentiality when it comes to like child abuse. So those kind of things actually clarified my doubts. So I'd really like to thank you for taking up your time and just discussing this with us. So yeah.
Thank you. If you want to later, maybe one of you can communicate with me. I can even share some books or chapters that highlight this in more details, plus other issues that we could not actually cover. But thank you for your comment. Appreciate it.
Will do. Thank you so much, sir.
Welcome.
Thank you, Hasma. Thank you very much. Anybody else? Please go ahead. This is our time with Professor Samir to have this dialogue. So go ahead.
I have a small question.
Yes, Sabiha.
So when we were speaking about breaking
Sabiha, I can't hear
confidentiality,
you. You're very distant.
you hear me now?
No, not my side. Louder, please. I'm not young, though. That's why I came
Can you
close
hear
to
me now?
the speaker. Yeah, now, yes. Go ahead.
Okay. So I had a small question regarding breaking confidentiality when it comes to things like weapons, crimes, and things like that. So how can we make an appropriate assessment that the client does plan on carrying out what they say they're going to do? Or when can we break that confidentiality? Do we do it as soon as the client says, okay, I'm planning on doing this? Or do we try to explore a little bit more to see if they're actually going to do it? Because if we break confidentiality and they were not planning to do it, then that could affect the therapeutic relationship. So how do we make that assessment?
Yes, good point, because that can be, a neuropath, difficult issue. So most of the time, there's something called risk assessment. And maybe you could share among yourself, particular, my reading, Sri Lanka has, let's use as a suicide as an example here. It's quite like it's increasing all over the world. It was one time Sri Lanka was quite high. So better to assess the, this risk factor, like if someone, comes and threaten has a weapon and all that, it could be attention seeking, or it could be just he want to vent and all that. It's actually very difficult to decide, but if you feel now after if let's say you have a session with them every week, you can tell them, I want to see you tomorrow, even for short time, just to be sure, in case that sleepover has not made them recover. But it's true that it's very difficult. But some issue can be, the context can be, we cannot risk like somebody threatened to commit suicide. And then if you do risk allowance, you may want to make sure that In case you don't know what will happen, to protect yourself, better put it in your notes. Okay, the patient has threatened this, and I told the patients to go to emergency department or to stay longer, or it depends what sort of services that where you are working. But this can be actually a difficult stage. We can always not prevent, but whenever you see danger or something that border this sort of thing that could backfire, someone threatening suicide or this, just document it for your own protection. And if you are already having this proper risk assessment and the patients appear to be genuinely going to do this danger, then you can inform the authority, or there must be some, area of psychotherapy, psychology, clinical psychology, health psychology are not well developed in many countries. I'm not sure about Sri Lanka. Oman is like that. But in many countries, there's a clear, like algorithm. If this happens, you have to report this. Some of those, like child abuse and other things, we do have in Oman. So we have the office specifically, they take phone call for that one to break the confidentiality. Okay, good question there. Thank you.
Thank you, Doctor.
Yes, Abhi.
Welcome.
Thank
Welcome.
you, sir. Anyone else, please feel free to go ahead and ask or share.
I have a question, Professor Samir. Hello,
Go
am I
ahead.
audible?
I can hear you, yes.
Professor Samir, amidst the presentation, I have heard that purchasing couple of sessions at once or reserving an entire day can be a sort of manipulation. So I want to know more information about that. How can it be a manipulation? This is my question.
Yeah, so manipulation is quite difficult to, it requires some experiences, but it's always difficult to to be certain what you are doing. So the way forward is, you should not be suspicious to operate that way, because you'll become very defensive. Try to, as they say in some sort of psychotherapy, unconditional positive regard, rather than become very defensive. And some of the earlier the story may not be genuine, because some people come up with masks when they do little bit, little bit, little bit. So some of them tends to be, like in the beginning seems very outrageous, but after they come down, you get better picture of the situation. We see nowadays, because of the narrative in the world, like everyone, want to get attention. So we see these young generations, they call it Gen Z. You were aware of that, I think. Maybe some of you are Gen G, Generation Z. So they like to shock sometime, like they say this and this and this, and then we get to know them, and you ask them questions, and they don't even remember that they told you. But so some people just like it's attention seeking. But again, to go back to your original question, this area is quite difficult. If you are interested in that area, there's a special training called forensic side, plus there are some way of ruling out malingering or others. There even a test called Minnesota Multiple Personality Inventory, MMPI. It's a old test, is very cheap actually. So you can ask the patients to do, and you can get whether, the good thing about this test is very long, but it can reveal whether they are faking good, faking bad. So whenever we see someone very suspicious like that, we ask them to do MMPI. And it also tells you how they are likely to respond to treatment. So, and they ask them so many questions, and it can tell whether they are faking good or faking bad. You know, there are some ducking or trying to exaggerate some questions. So maybe those of you who are interested can read about it. And we have Arabic versions, but even international versions are very cheap. And then it's good to start because when you give it to the patients, you will get to know more that what do they have. Sometimes they say something like they have a psychotic illness, but in fact, they are just those people who like to imaging things like that. So they may be more like a schizoid rather than having schizophrenia or psychotic symptoms. So if you forget that name, Rushma can reach me. I can give you the name. It's called MMPI, Minnesota Multiphasic Personality Inventor. Very old test, but quite useful for this sort of thing. It's often used with forensic teams, when the patients deny or things like so they are away, but they are not very, very quick. But if you feel you encounter them, then maybe it's worth to prepare for, that test, to use that test. And it doesn't require specialty or anything. You can get it, from the vendors like, those who sell the psychological tests, like Pearson, for example. If you just put it, it's there in the system. And maybe you can get it with local language. Arabic has more speakers than Sinhalese, for example. So many things nowadays are available in Arabic. Yeah, interesting question, Hiranti. Is your name Hiranti?
Yes,
It's
Professor
written there.
Samir.
Yes, Professor Samir. Okay. Thank you for the question.
Thank you for answering, Professor Samir.
You're welcome.
Everyone for your interesting questions. Thank you, Professor, for that very enlightening um, talk and a lot of questions to ponder on. So I'm also leaving today with like, okay, Rushma, there's a lot of reflection you need to do about your own practice. I thank you so much. As always, having you, talking to you, any brief conversation with you, I have always learned so much, and I'm quite sure it's the same for everybody on the group, sir. We have come to the end of our call today. However, Professor, what we want to do is, would it be okay with you that we stop the screen share and we just want to take a screenshot with everybody, and everyone, those of you who can switch your videos on, could you please switch your videos on and we do a quick, photograph with Professor, if that's okay. Okay, so thank you, Maiden.
Hello, everyone. I see
Hello.
your face now.
Sabiha, Nafla, Bayanga, Oshani, Monadi, Hasini. There are a few others who had network issues. So I'm going to invite you to, I think Hiranti, you might be able to stop Professor Samir's screen. Hasini, can we have your video on? Oshani and Sabrina as well. Thank you. One more last time. Farha, could we have your video switched on as well so we can take a quick photograph, a quick snap, a screenshot? So this is how we do it these days, right? The screenshot. Thank you, Vayanta. Hiranti, whenever
Thank
you're
you.
ready, give us the cue and we're all gonna smile.
Okay.
Are we all ready? Good. Everyone has their best smiles on. Are you on the right side? Is it your left side or right side looks better? Okay. So I'm gonna 3, 2, 1, screenshot, stay. Great. Thank you. I took one. Thank you so much, sir. Thank you very much.
Feel free to share the PowerPoint that came to you. Yeah. It's not copyrighted, so you can start teaching using them.
Okay. Thank you very much. We'll do
Thank
so.
you,
Thank you very
everyone.
much.
Bye. Keep in touch, please,
Bye,
and good luck.
everyone.
And thank you for
Thank
inviting
you.
me.
Thank you, sir,
Bye.
for honoring us with your time. Thank you.
Bye.
Bye.